Welcome to the deep dive. Today we're tackling a really foundational, high-stakes area of professional life, the safe and, effective supervision of junior staff. If you're getting ready for assessments like the MSRA SJT, that's the multi-specialty recruitment assessment situational judgment test, or you just want to be sure you're meeting the highest GMC standards, then this is definitely for you.
It's a huge topic, isn't it? And it's high frequency for scoring well.
Yeah.
But honestly, it goes so far beyond any exam room. It's all about creating patient safety systems that are, resilient.
Right.
So today we're pulling from detailed textbook notes, official UK guidance, really just to isolate those few key actions that reliably balance patient risk with the absolute need to develop our colleagues.
Exactly. We're trying to move past the textbook and get into the practical side of it. So let's set a scene. You're the senior on call. It's late. An FY1, a very junior doctor, has just admitted a complex patient, and you can just tell they're hesitant.
You see it all the time.
Yeah. And they've been asked to review some abnormal bloods, including a really worrying potassium level. You know they need guidance, but you've also got two emergencies kicking off. What specific framework do you use to make that handoff safe?
And that tension is the heart of it, isn't it? The workload versus the responsibility to teach. Our mission here is to give you the structure to manage that chaos without, abdicating your responsibility. We have to start with the core principle. The ethical framework says supervision can range from direct, so you're literally in the room with them, to indirect, where you're available remotely for support and, crucially, for review.
And here is the central truth, the thing that I think carries all the weight. When you delegate a task, you do not, under any circumstances, delegate the ultimate accountability. Not for the task, and certainly not for the patient.
That is the essential insight. That's it. The senior always remains professionally responsible for making sure the task, the system, and the level of supervision are all appropriate for that specific situation. The GMC standards, the SJT, they fundamentally reward risk-matched oversight.
Okay.
So if the task is high risk, or the junior's competence is, say, unknown or low, the supervision must be direct and explicit. It's not optional.
So if we break down what reliably scores points, whether that's in an exam like the SJT or in a real-life patient safety review, it always boils down to showing three things every single time.
Yep. First is risk-matched oversight, just like we said, matching direct versus indirect supervision to the risk of the task and the concerned competence of the person doing it.
Right.
Second, structured communication. We're talking clear briefs, setting specific non-negotiable thresholds for when they have to call you, and always using a closed-loop confirmation system.
And the third?
Accountable follow-through. So being reliably reachable, actually reviewing the outcomes promptly, and this is the bit people forget, documenting the whole process.
I think the big mindset shift here is so critical. You're not looking for the easiest or the fastest solution. You're looking for the most structurally safe solution.
Exactly.
And that means clarity, accessibility, and documentation. They just have to beat convenience every time.
Every single time.
Okay, so let's take that theory and build it into a practical kind of dynamic approach. Our sources give us this fantastic framework, something you can actually use under pressure using the mnemonic guide.
Guide. It's a good one. It gives you 5 clear steps. It takes you from just delegating something to actually building a safety net around it.
Okay, let's start with the assessment phase then.
So G is first, grade supervision. You have to explicitly decide what level of oversight is needed here. Is it direct, indirect, or maybe a kind of hybrid where the junior does the first bit and you review the key steps with them?
And that grade is based purely on that risk versus skill balance.
Precisely. Which leads you straight into step 2, the U. Understand competence. Now, this is maybe the hardest part to get right when you're under pressure. You have to explicitly assess their competence and, just as important, their confidence.
Don't just assume.
Never assume that because they're at a certain stage of training, they've done a specific task before.
Okay, I have to push back on that a little bit, though, because when you're busy, it's so easy to just think, well, the handbook says an FY1 should know how to do X. How do you quickly and safely check competence when that junior, the FY1, or maybe a physician associate, is a bit anxious or maybe doesn't want to admit they've never done it before?
That is a brilliant question, because that's exactly where unsafe practice begins, with an unverified assumption. Safe assessment means you have to ask open, non-judgmental questions.
So not just, can you do this?
No, never that. It's more like, how many times have you done this procedure? before? Or what were the challenges last time? Or even better, can you just quickly talk me through the checklist you'd use?
Oh, I see.
You listen for the hesitation in their voice. If there is any doubt at all, you must default to direct supervision or at least guided practice. You're not just protecting the patient. You're explicitly protecting them from a situation they're not ready for.
I love that shift from "can you do it" to
Yep.
"talk me through the steps." It gets the information without making them feel like they're failing. Okay, so moving on. Step 3 is I. Instruct via SBR.
Yes. SBR situation, background, assessment, recommendation, it's essential. Not just for handovers, but for really clear delegation.
Why is it so crucial here?
Because it forces a structure on it. It ensures there's clarity on what the task is, why it's important, the specific red flags to look out for, who owns the results, and maybe the most crucial bit, when a formal review has to happen, it eliminates all the ambiguity.
Okay, that makes sense. Next up, step 4, the Ds. Dial up availability and thresholds. This is the safety net itself.
It is. You have to be contactable. Carry the bleep, tell them where you are, and actively encourage them to escalate.
And finally, step 5, the E.
Enter notes and review. This is what guarantees continuity and accountability.
Yeah.
You have to review the outcome of the task promptly, and you've got to document the whole plan.
Yeah.
The supervision level, the instructions you gave, and any learning points for the junior.
Okay.
So we just walked through the guide framework, but let's zoom in a bit more on the communication piece, so steps I and D, because that's where accountability is really tested.
Right.
And this brings up a really important question. Just how specific do those escalation thresholds need to be?
My assumption here is that the sort of vague, friendly advice of, oh, just call me if you're worried, that's not going to cut it. It needs to be objective.
It's utterly insufficient. In a formal review, that would be seen as a significant patient safety failure. Safe practice demands extreme objective specificity. You have to name concrete, measurable triggers.
You mean actual numbers?
Yes. We're talking physiological signs. A new WS2 score of 5 or greater, that's the National Early Warning Score. Or specific lab results, like a potassium level above 6.0, which is an immediate cardiac risk. You have to give them objective markers they can rely on.
And then once you've given that instruction, the communication loop isn't closed yet, is it? We mentioned closed loop confirmation.
Absolutely essential. Safe practice means you ask for a readback. You actually have to say the words, just to make sure I was clear, can you repeat the plan? And the call triggers back to me.
It feels a bit formal, but I see why it's necessary.
It confirms mutual understanding. It's a non-negotiable hallmark of safe clinical practice.
Okay, so let's give the listener some, model phrases. What does high-scoring, safe communication actually sound like in the moment?
Okay, so for procedure, you model safety. Something like, for this first lumbar puncture, we'll do it together now. I'll talk through each step. And you must verbalize the safety checklist before we start.
Right, that's direct, it's explicit, it's focused on teaching. What about for remote delegation?
Be explicit about the criteria. If the patient's new WS2 hits 5, or if the potassium hits 6.0, or if they report any new chest pain, or even if you're just worried, call me immediately. I'm in CDU, bleep 123.
Clarity, objective triggers, contact method, and permission to call, even if they're just unsure. That really covers all the bases.
And this ties right back to the E and guide documentation. You have to create that audit trail.
So what absolutely must be recorded?
The level of supervision you decided on, the explicit instructions you gave, the specific thresholds for escalation, who owns the results for review, and the time by which you will personally review the patient or the data. That is what assures continuity, especially over a shift change.
This is where it gets really interesting, I think, because now we need to talk about the danger zones, the red flags, the situations where you have to intervene, and it is absolutely non-negotiable.
These are the moments where speed and decisive action, all driven by safety, are paramount.
Okay, red flag number 1. A novice is assigned a high-risk procedure alone.
Immediate stop.
You have to step in, verify competence, and switch to direct supervision, or just redelegate it completely. Red flag number 2. Abnormal, time-critical results like that high potassium are just sitting there unreviewed, even if they were delegated hours ago.
That's a clear oversight failure. It demands urgent senior review, and someone has to take ownership now.
Red flag number 3. The supervisor is unavailable or uncontactable.
Your safety net is broken. You have to immediately hand over your supervisory role to a colleague who is accessible, or you have to make yourself available again. No safety net means unsafe practice. Period.
And finally, red flag number 4. The supervisee is distressed. They're clearly exhausted or just operating way beyond their limits.
You must intervene. You pause the task, you support them, you have to prioritize patient safety and also that junior's fitness to practice.
Okay, so now let's talk about the sneaky traps, the decoy detectors. These are the options that, they can feel efficient or helpful in the moment, but they actually violate those GMC principles of accountability and structure.
Right, they represent unsafe practice. And the most common and probably most dangerous decoy is framed around convenience and a kind of false independence. For example, a classic trap answer is, tell the junior to try the procedure alone and just call if they fail.
That's an immediate failure of risk-matched oversight. Why does that score so badly?
Because it completely ignores their competence and the risk assessment until the moment of crisis. Until actual harm might have already occurred, it's just too late. It shows a severe lack of structured oversight.
That's another one.
Another low scorer is, I'm busy. Just text me the key details later.
Ooh, that's a bad one.
It immediately blocks effective real-time escalation. It makes you functionally uncontactable for the most critical situations.
Or the really vague delegation approach.
Yes, the keep an eye on the patient in bed for. It sounds flexible, but it's just dangerous. It's useless. There are no objective thresholds, no explicit owner for the review, no timing. It is basically supervisory abdication.
And what about documentation?
Ah, yes. Never, ever choose an option that suggests avoid documenting the plan to keep things flexible. That creates zero audit trail, zero continuity, and it puts both the junior and the patient at huge risk if the shift changes.
So the golden rule is really clear then. The right supervision level, delivered with a clear SBAR brief by a reliably reachable senior and recorded in the notes. That is the safest, most professional, and highest scoring path every time.
Let's apply this to that mini scenario we talked about at the start. So you're the evening medical registrar. You've got a hesitant FY1, a physician associate. They're covering 24 patients, and there are multiple abnormal results pending, including that high potassium.
Right. The temptation is to just say, look, I trust you too. You're smart. Just prioritize the sickest patient and call me only if they crash. It's fast and it feels like you're empowering them. But why is that so low scoring?
Because it fails on structured communication and on risk matching. Telling them to call only if they crash forces the junior to manage that high risk alone, and it delays vital senior input until the patient is potentially, in cardiac arrest.
Right.
That violates the GMC principles of timely intervention and safe systems.
So the best action is always to set explicit structured supervision.
Precisely. The high-scoring, safe action is defining exactly where you are, using SBAR to delegate the review of the bloods and the plan for the patient, setting specific call thresholds, new WS2 of 5 or more, and allocating a specific time for when you'll review the results, and then documenting that whole agreement.
It sounds like it takes more time up front, but I guess that initial 3 minutes of structure probably saves you hours of panic and potential harm down the line.
Absolutely. And, this isn't just about managing risk. It's also about building a supportive workplace culture, which the GMC really stresses in good medical practice. Why do juniors so often not call seniors?
Because they're scared of bothering them or being criticized for calling too early.
Exactly. That psychological safety is key. Safe supervision means you have to actively dismantle that fear.
How do you do that?
By modeling civility when you get a call, no passive-aggressive sighs. By inviting early calls, saying call if you're unsure, and by positively reinforcing when they do escalate in good time. If you treat the junior who calls about a new WS score of 4 politely, they will 100% call you when it hits 6.
That's a brilliant point. Now, to bring this all together, we introduced guide, but there's another great secondary memory hook for the supervisory mindset. It focuses on how we should behave as seniors. ABL.
Yes, ABLE is a great quick check for team safety just before you delegate. A is for available, B is for boundaries setting those objective thresholds for when to call. L is for learning focus, making sure the junior is actually developing, not just doing scut work. And E is for evidence and notes, documentation.
If you are ABLE, you are supervising safely. I like that. This has been a really robust framework for managing risk and ensuring professional accountability. Let's just recap the 3 non-negotiables for everyone listening.
Okay. First, match your supervision to the risk and the skill. Always define the level explicitly. Is it direct or indirect? No ambiguity.
Second, give SBAR briefs with concrete, explicit triggers, we're talking specific numbers and symptoms, for when to escalate, and always use that readback.
And third, be reliably reachable. respond civilly, and actively welcome the call for help, even if the junior is only unsure. Remember, the safe call is the one that prevents the harm in the first place.
We've established that the supervisor is accountable not just for their own actions, but for the entire system of safe practice. So the question for you to think about on your next shift is this. Knowing how critical psychological safety is to patient outcomes, how will you actively dismantle that fear of bothering a senior in your workplace? How will you make sure every member of your team feels empowered and safe to escalate a concern?
That is how we practice good medical practice today.
Thank you for joining us for this crucial deep dive.
Until next time.